Hello, my name is Emma Strio, and I am a health project coordinator with Highland Family Medicine Research in Rochester, New York, working on implementation research translating the ABCs into HIV care. Specifically, this clinical trial is supported by the National Heart, Lung, and Blood Institute, and today joining me is Rebecca Roper, our project officer from NIH. Translating the ABCs into HIV care is a step-wedge cluster randomized trial that is testing implementation strategies designed to specifically promote the uptake of evidence-based cardiovascular interventions for people living with HIV. Now, these implementation strategies are called the ABCs. Taking aspirin, controlling blood pressure, reducing cholesterol, and smoking cessation. Specifically, implementation strategies target patient, clinician, and practice participants. Now, this study is looking to recruit 600 largely low-income and minority patients who must have HIV. They have to be between 40 to 75 years of age with a 10-year cardiovascular disease risk score of 5% or greater, specifically using the ASCVD Risk Estimator Plus calculator. Of course, having to be willingly participate, be proficient in English or Spanish, own a cell phone with texting capabilities, and be approved by the consented clinician on the study as well. And this study overall is looking to recruit 40 to 60 clinicians who care for these patients specifically around 9 separate practices, largely serving low-income and minority patients from 3 geographic regions: in New York City, Rochester, New York, and Dallas, Texas. Overall, recruitment for the study involves identification of potentially eligible participants using electronic health record data, having communication between the clinician and research assistant at that location, any referrals made by the clinician specifically, and communication between prospective participants, research assistants, and clinicians. Pre-COVID study methods incorporated throughout the Clinical Directors Network in New York City, UT Southwestern Parkland Health and Hospital System in Texas, and the Infectious Disease Clinic in New York were able to adopt warm handoffs to facilitate patient recruitment and enrollment. Specifically, patient screening was conducted on-site at the given health center throughout the geographic locations, while assessments could be both conducted in person and over the phone pertaining to participant preference. Now, of course, strenuous schedules and clinical demands did negatively impact referrals of eligible patients from time to time. In the beginning of March 2020, all health sites from Dallas, New York City, and Rochester, New York experienced a sudden institutionally COVID-19 mandated shutdown of in-person clinical and research activities throughout clinical trials. Now, hospitals, clinics, and federally qualified health centers quickly transitioned all non-emergent urgent patient visits to telehealth visits by video or phone, often from clinicians' homes due to the fact of remote work beginning. Now, clinical trial recruitment is challenging, particularly for socially disadvantaged patients, and the COVID-19 pandemic has definitely amplified this challenge. Now, these transformative changes required immediate adaptations for our research team and interventions, specifically working on completely shifting in-person assessments and coaching to all online, and rapid adoption of telerecruitment and teleconsent procedures. Specifically during this time, transitioning all paperwork and study materials that were being provided to patients in person to being able to complete them remotely over the phone and mail all study documents to participants. Now, New York City confronted an epic surge in COVID-19 patients, impacting hospitals and health centers that serve low-income, uninsured, and minority patients. Rochester, New York had the second largest number of people confirmed with COVID-19 outside of New York City, but area hospitals never approached capacity. And Parkland Health and Hospital System is funded by Dallas County to be able to provide that primary care and hospital care to low-income, uninsured minority patients. And Dallas County was second among Texas counties in the number of confirmed COVID-19 cases and patients. As COVID-19 is ongoing, all health sites at the Clinical Directors Network in New York City, UT Southwestern, Parkland Health and Hospital System in Texas, and the Infectious Disease Clinic in Rochester, New York, transitioned from having adopted those warm handoffs in person to completely virtual outreach, patient recruitment, enrollment, and remote study visits. Now, throughout COVID, many clinicians were pulled to in-service to be able to address the needs of patients that were hospitalized with COVID-19. And revised strategies substituted electronic communication with the clinician for face-to-face communication. Now, there was a lot of built-up stress and anxiety of coping with the pandemic, specifically in New York City, which prevented many patients from answering their phones and reduced their willingness to enroll. And some patients even shared at the clinics in New York City that they were diagnosed with COVID-19 and were in the process of recovering. And one particular patient in the ABC study from New York City died after being hospitalized with COVID-19, unfortunately. Now, at the clinician level, participating clinicians reported having to focus their attention solely on pandemic-related demands. Therefore, recruitment rates decreased due to competing demands by busy clinicians, difficulty contacting the clinicians, and frequent changes in patient scheduling, which ultimately made potential participants and various patients hard to identify. Now, the introduction of remote procedures facilitated systematic deployment of opt-out procedures, and many patients seemed to welcome research participation during the shelter-in-place orders throughout the country, and specifically our geographic sites for this study. This table summarizes the different procedures deployed by each of the three geographic locations, their rates of recruitment pre-COVID-19 compared to throughout COVID-19 closures, and specifically how procedures were revised and specific challenges that were encountered. Now, our results illustrate how similar restrictions imposed by COVID-19 have had varying impacts on recruitment across three geographic locations. Local contexts, including competing demands, likely affected the relative impact of similar adaptations from in-person to virtual recruitment. Initially, slow recruitment in Rochester accelerated with these changes, whereas recruitment slowed in New York City and Dallas due to challenges in engaging patients and clinicians. Now, pre-COVID, in-person contact with patients in Rochester, New York was challenging due to frequent changes with provider schedules, very busy offices, and patient appointments. And throughout COVID, conducting remote study procedures has proven beneficial for continuing efficient communication with clinician and patients and opt-out recruitment. In Rochester, clinicians approved patients and permitted proactive remote outreach, resulting in higher rates of recruitment post-COVID and throughout this pandemic. Now, in contrast, COVID-19 disrupted previously efficient recruitment processes at the other two sites. Now, the Dallas site adapted by allowing more time to remotely contact and consent patients. This has required additional time, effort, and patience in accommodating social needs of an impoverished group facing the COVID-19 shutdown. The Clinical Directors Network in New York City and their team implemented strategies for overcoming these specific barriers. The team reminds patients that study participation does not require in-person visits or public travel, of course, which may reduce concerns regarding potential COVID-19 exposure. And also the team conveys the importance of cardiovascular disease risk reduction even in the midst of the pandemic, throughout all geographic locations. And finally, overall, the team now conducts periodic check-in calls to briefly provide clinicians with study updates and to discuss details related to patient enrollment, as well as throughout all sites, communication via email has been very efficient. Overall, the COVID-19 pandemic has required rapid adaptations of recruitment processes in order to be able to preserve trial integrity. Our experience overall suggests varying effects on recruitment that are unavoidable, and local contextual factors in two big cities sites impacted our team's ability to electronically reach and engage patients in research during the pandemic. As the country and specific city sites start to open and adjust to social distancing measures, while learning more about COVID-19 implementations, health centers will continue to ensure patient participation, safety, and confidentiality, of course. Our results caution trialists that rapid conversion from in-person trial activities to all virtual activities during events such as COVID-19 have a varying, unpredictable impact on recruitment, at least short term. Now, overall, throughout our study and throughout these trying times and tribulations, challenges with COVID-19 and all clinical trials, we as a team want to recognize the promptness by which we all pivoted in scientific fashion, where we were both able to be proactive and patient when considering the impact on clinicians themselves, as well as our adaptive approach to be able to keep up with accrual and retention throughout all sites and geographic locations throughout the study. This slide represents a few of our references that we have utilized and looked into throughout our study of the ABCs, as well as during this research time of coronavirus and COVID-19 pandemic. Thank you everyone for taking the time to learn a little bit about translating the ABCs into HIV care, as well as our study implications during these trying times and tribulations of COVID-19. Have a great day.